All right, let's jump right into this Step 2 CK Explainer. We're going straight for those high-yield, test-day decision algorithms. We'll kick things off with acid-base logic, and then dive right into mastering dermatology visual diagnoses. Let's go.
Okay, so for literally any metabolic abnormality question you see, your rock-solid foundation is the arterial pH. If it's under 7.35, boom, you have acidemia. Next move, check the bicarb. If it's less than 20 milliequivalents per liter, you're looking at metabolic acidosis. And at that exact moment, this is non-negotiable, you have to calculate the anion gap. That's just sodium minus the sum of chloride and bicarb.
So why do we care? Because distinguishing between a high and normal anion gap instantly narrows down your differential. It's like a cheat code. For a high anion gap, meaning anything over 12, you want to apply the gold mark mnemonic. This covers causes like uremia from renal failure, lactic acidosis, or diabetic ketoacidosis. But if you have a normal gap, say between 8 and 12, switch over to the hard-ass mnemonic. That's going to catch those test favorites like renal tubular acidosis or severe diarrhea.
All right, let's test this with a classic board vignette. Picture a pregnant patient presenting with hypertension, edema, and a malar rash. What specific test finding distinguishes a systemic lupus erythematosus flare, an SLE flare, from preeclampsia? Take a second to think about it.
Got it? The immediate answer is RBC casts and WBC casts on the urinalysis. You're also going to see decreased complement levels and increased ANA titers. These specific markers are absolutely crucial because they separate a lupus nephritis flare from preeclampsia, and that distinction guides you straight to the right management step, which ultimately is a renal biopsy.
Now, what if you suspect drug-induced lupus? Here, the timeline is everything. It typically requires more than 3 months of high-dose use of known offenders. Think procainamide, hydralazine, or penicillamine. And the classic test clue to look for, positive anti-histone antibodies. You'll see these in over 90% of cases, especially in patients who are slow acetylators.
Okay, here's another vital autoimmune distinction: Sjogren's syndrome versus age-related dry eye. Sjogren's is defined by positive anti-Rho, also known as SSA, and anti-LAW, or SSB, antibodies. It frequently causes actual tissue injury or even digital ulcers, and it typically strikes women under 30. Age-related dry eye, on the other hand, it lacks those autoimmune markers entirely, has absolutely zero tissue injury, and mainly affects older patients. Simple as that.
All right, shifting gears to our dermatology algorithms, I want you to lock in this physical exam clue. A patient presents with a swollen, hot, red leg. It has sharply defined borders, and get this, there is external ear involvement. What's the diagnosis?
The answer is erysipelas. That external ear involvement is the ultimate key clue here. But why? Well, it's because the external ear actually lacks a lower dermis. That one anatomical fact effectively rules out cellulitis, which is a much deeper skin infection that involves the deep dermis and subcutaneous fat. Erysipelas, which is mostly caused by Streptococcus pyogenes, is restricted to the superficial dermis and lymphatics. That's exactly why it has those raised, sharply demarcated edges and comes on so rapidly.
Building on those common skin infections, let's talk impetigo. It has 2 really vital presentations you need to know. Non-bullous impetigo gives you those classic honey-crusted papules and pustules. The bullous form, though, features these enlarging, flaccid bullae filled with yellow fluid and a peripheral collouette of scale. That one is driven specifically by Staph aureus exfoliative toxin A. For limited non-bullous cases, you treat with topical mupirocin, but you need to step up to oral cephalexin for extensive or bullous cases.
Next up, diaper dermatitis. Here, distinguishing the cause directly dictates your treatment. Candida dermatitis shows up as these beefy red confluent plaques with smaller satellite lesions. And critically, this is the big one, it actively involves the skin folds. Irritant contact dermatitis, which is just driven by stool and urine exposure, strictly spares those skin folds. That one visual rule instantly guides you to either use a topical antifungal like nystatin for the candida or a simple barrier cream like zinc oxide for the irritant.
Let's move on to pigment disorders. Sharply demarcated, completely depigmented patches, that characterizes vitiligo. It's an autoimmune loss of melanocytes, often showing up on the face, hands, genitalia, and acral surfaces. You really must remember its association with other autoimmune diseases too, things like lupus, pernicious anemia, and Addison disease. If the disease is limited, you treat with topical corticosteroids, but for extensive cases, you're looking at calcineurin inhibitors or PUVA.
Now, whatever you do, do not confuse vitiligo with tinea versicolor. Under a wood lamp, vitiligo shows completely absent pigment, and a biopsy will prove an absolute absence of melanocytes.
Tinea versicolor, however, is a Malassezia fungal infection. It only causes partial hypopigmentation with a fine scale. If you do a potassium hydroxide prep, you'll see its classic spaghetti and meatballs pattern. Real game changer for telling them apart.
Okay, let's talk about the sun, because sun exposure drives some major skin pathology. First off, remember melasma. It presents as irregular hyperpigmented facial macules, really commonly seen in women or during pregnancy, and it requires strict UVA and UVB broad-spectrum sunscreen. Now, for acute sunburns, symptoms usually peak hours after exposure and resolve by days 3 to 7. Mild cases? They just get cool compresses, Calamine, and NSAIDs. But watch out for severe cases. If there's blistering, fever, or vomiting, that mandates hospitalization for IV fluids and pain control.
Let's walk through the strict step-up therapy ladder for acne vulgaris. For comedonal acne, start with topical retinoids, or salicylic, azelaic, and glycolic acids. For mild inflammatory acne, you add benzoyl peroxide. Moderate cases, add topical antibiotics. For severe nodular acne, you're stepping up to oral antibiotics, and if it's completely unresponsive, use oral isotretinoin. Also, keep this in mind. For women with moderate to severe premenstrual flares on the lower face, you can utilize combined oral contraceptives or spirolactone. Just remember, spirolactone carries a risk of male fetal feminization.
Time for a quick pause. Here's a classic two-step pharmacology interplay you need to recognize for test day. What common antibiotic class, frequently used for that severe inflammatory acne we just talked about, triggers a classic photosensitivity reaction?
Did you guess tetracyclines? Yep, drugs like doxycycline. You have to advise these patients to use strict SPF 30 sun protection to avoid severe erythema. And hey, while we're on the topic of medications, watch out for drug-induced acne from things like glucocorticoids or anticonvulsants. This presents as monomorphic papules that are all in the exact same stage of development. The management there is straightforward. Just discontinue the offending drug.
Speaking of facial erythema, let's look at rosacea. This condition is famous for flaring up with triggers like hot weather, hot drinks, spicy foods, or alcohol. Management here is uniquely targeted based on the exact presentation. The absolute next best step for papulopustular rosacea, which has those small papules and pustules right on the central face, is first-line topical metronidazole, azelaic acid, or ivermectin. But if your patient presents with the erythema telangiectatic flushing type, where flushing and telangiectasias are the main issue, you treat that specifically with topical brimonidine. It acts as a vasoconstrictive alpha-2 agonist to calm that redness down.
Quickly pivoting to pediatric dermatology, you definitely need to recognize congenital dermal melanocytosis. These are benign, blue-gray patches typically seen on the sacrum and buttocks of infants of color. They are completely harmless. Your only next step here is to accurately recognize it and reassure the parents no treatment needed.
All right, to wrap up this explainer, let's cement these clinical rules with a rapid rash pattern summary. Ready? Sharp borders on a hot, swollen leg with ear involvement means erysipelas. Honey-crusted papules, that equals non-bullous impetigo. Beefy red satellite lesions that actively involve the skin fold strongly suggest candida, and strictly demarcated, completely depigmented patches indicate vitiligo. Master these visual anchors and structured algorithms, and you won't just pass your exam, you are going to absolutely dominate the wards.